Allison Cihla. I am a pulmonologist at Preston Memorial Hospital in Kingwood, West Virginia, where I also serve as the medical director of intensive care and cardiopulmonary services and the medical director of the Grace Ann Dorney Pulmonary Rehab Center. I also serve as the consulting pulmonologist for the Appalachian Pulmonary Health Program. So today we're going to be talking about chronic lung disease. Our objectives are to define COPD and the impact it has on the healthcare system, to discuss risk factors for COPD, learn the symptoms of COPD, and discuss the importance of spirometry and its diagnosis and prognosis for COPD, discuss the refined COPD assessment, and learn about additional investigations that may help to establish the diagnosis. So first, we'll start with a patient presentation. The patient that we'll sort of be coming back to at the end of this presentation is a 63-year-old male who presents to the office with shortness of breath on exertion that's been worsening over the last few years. He gets bronchitis 3 times a year, but has never been hospitalized. He is a former smoker. He smoked 2 packs of cigarettes a day for 35 years and quit smoking 8 years ago. He has a daily cough, productive of sputum, low energy, and shortness of breath with his daily activities. His oxygen saturations are 94% on room air. So the first question is, what is the diagnosis, and what evaluations does he need to make the diagnosis and to determine his prognosis? So we'll talk a little bit about COPD. It affects roughly 6.5% of the population, but in West Virginia, it affects between 12 to 13% of the population. It's the fourth leading cause of death in the United States. And in 2021, more than 3.5 million people died of COPD. It's responsible for about 6% of all deaths globally. It's important to us because it is a high resource utilization. These patients come to the clinic more frequently, they're hospitalized more frequently, and they need chronic treatments that can be costly. The annual cost for COPD treatment in West Virginia is about $249 million. So you can see that it can put a strain on our healthcare resources. I'm just going to minimize the pictures. Give me one moment. Okay. So what is COPD? COPD is a chronic inflammation that then leads to structural changes in the small airways where they become more narrowed and the lung parenchyma starts to break down. So you can see in A is a normal airway, and you can tell the difference in B. You've got this thickened wall around here, and you can start to see some destruction of the lung tissue. In C, you can start to see sort of some fibrosis or some stiffening of the walls. The walls get thicker, they get narrower, and that continues in D. And so you can tell between picture A and picture D why these patients may have more difficulty breathing, because instead of breathing through a nice open airway, they're trying to breathe through this fibrosed, narrowed, thickened airway. So these changes then lead to mucociliary dysfunction where you're not able to clear the mucus. These patients have persistent respiratory symptoms and airflow limitation. Usually this is caused by significant exposure to noxious particles or gases. The most common that we tend to see is cigarette smoking, although definitely not the only cause. These patients most commonly present with shortness of breath or dyspnea, cough, with or without sputum production. They can have acute periods where their symptoms worsen, which we term exacerbations. And usually these patients have significant concomitant chronic diseases, which increase their morbidity and their mortality. Heart disease is common, diabetes is another. There are risk factors and exposures, as well as some host factors that predispose patients to development of COPD. So if you look at the etiology, we think of smoking and pollutants as a major factor, as well as some underlying host factors. These things then change the pathobiology of the lungs, where these patients have impaired lung growth, they have accelerated decline of their lung function, lung injury, and then systemic inflammation. This leads to small airway disorders or abnormalities, as well as emphysema and some other systemic effects, which then manifest as airflow limitations and these clinical manifestations of symptoms, exacerbations, and comorbidities. So basically, this is what I just talked about, but just in a graphic form. Major risk factors for patients developing COPD include tobacco smoke, indoor air pollution, occupational exposures, outdoor air pollution. There are some genetic factors, age and sex. Men and older people are more prone to get COPD than younger people. Lung growth and development. We tend to see some chronic changes in patients that were maybe premature or had some other exposures as children. Socioeconomic status does play a role. Patients with asthma and airway hyperreactivity are more prone to develop COPD, as well as patients with chronic bronchitis or recurrent infections. So any patient that has shortness of breath, chronic cough or sputum production, history of recurrent lower respiratory tract infections, or a history of exposure to these risk factors should be considered as a possible candidate as having COPD. You can see cigarette smoking again is probably the most common. On the right here, we see some occupational exposures, and in the middle, we see biomass fuels, which is the leading cause of COPD worldwide. When you're thinking about COPD, dyspnea can generally be characterized as progressive, but gets worse with exercise. It can also be seen as persistent. Cough may be intermittent, it may be productive, it may be non-productive, and these patients may have a recurrent wheeze. Any pattern of chronic sputum production can be seen, so this is not really a characteristic that you can pinpoint to COPD. These patients always also have recurrent lower respiratory tract infections, and they have a history of risk factors. Host factors such as genetics, congenital or developmental abnormalities, tobacco smoke, smoke from home cooking and heating fuels, and then occupational exposures. Family history and or childhood factors include a low birth weight or childhood respiratory infections. And all of these are factors that would make you want to consider COPD in a patient. We'll move on to talk about symptoms. Dyspnea is chronic and progressive. It can vary from day to day. Patients have good days, patients have bad days. Specifically, my patients tell me that they do worse when it's really hot outside and do better when it's cooler outside. This is a major cause of disability and anxiety in these patients. They can describe their shortness of breath as a sense of increased effort, heaviness in their chest, air hunger, gasping for air. There's lots of different ways that they can describe their dyspnea. Cough is often the first symptom that patients develop, and I don't know how many times I've heard it. Patients come in and they're like, oh, it's just my smoker's cough. It's my smoker's cough. But it doesn't get better when they quit smoking, or it gets progressively worse. And that can be the first symptom of COPD. It could be intermittent at first and then progresses to a chronic or a constant cough. And again, this cough could be productive or non-productive. Sputum production is difficult to evaluate as patients don't always cough that sputum up. It can be intermittent. It can worsen, especially during periods of exacerbation or infection. If patients produce large volumes of sputum, they're coughing up, I don't know, a coffee can full of sputum or, a couple cups worth a day, you may want to consider whether they have underlying bronchiectasis as well, because those patients do tend to be overproducers of sputum. Purulent sputum indicates an increase in inflammatory mediators. It may or may not indicate a bacterial infection. I know patients are always like, well, my sputum's green. Well, that, doesn't really necessarily mean that you need a course of antibiotics, but it does indicate that there is some inflammation happening. Wheezing and chest tightness. This can vary from day to day as well as throughout the day. Wheezing can be either inspiratory or expiratory. Chest tightness typically follows exertion. It's poorly localized as opposed to cardiac chest pain, which they point directly to one spot. It can be more muscular in character and generally thought to be secondary to contraction of the intercostal muscles, which is why it has a muscular type of characteristic. And these are very nonspecific. They do not confirm or exclude the diagnosis of COPD. Additional features, and these are typically seen in our COPD patients that have severe disease. They tend to have fatigue, weight loss, anorexia. They can have some ankle swelling, which leads to cor pulmonale, and can also have depression and anxiety. On clinical exam, you want to get a good medical history for these patients. What type of exposures or risk factors do they have that may predispose them to COPD? What is their past medical history? Specifically, do they have a history of asthma or allergies or other sinus conditions, history of infections or other respiratory diseases? Is there a family history of chronic lung disease? And what is the pattern of symptom development? Did it come on as an adult? Did it come on as a child? Um, do they get quote unquote winter colds? And how has this affected their social life and their ability to get out of the house and do things? Do they have exacerbations or previous hospitalizations? And do they notice worsening of their symptoms during this time? Patients with COPD tend to fall into two categories: patients that have frequent exacerbations and patients who don't have frequent exacerbations. And for whatever reason, they tend to stay in those categories. And that does help us as far as prognostication, which we'll talk about a little bit later. What other comorbidities do these patients have? Do they have heart disease? Do they have osteoporosis? Any type of cancer that they're being treated for? And again, how does their lung function impact their life? Are they missing work? Are they unable to care for, grandchildren or spouse or, whatever they may need to do? Are they suffering with depression and anxiety? And then well being and sexual activity. All of this can be affected not just by COPD, but by any chronic disease. But we do typically tend to see this in these patients. You want to find out what type of support they have. Do they have people that can help them if they get sick, that can take them to appointments, that can take them to pulmonary rehab? What type of support system do they have? And then what are the possibilities for reducing risk factors? Are they still smoking? Can we get them to stop smoking? Do they have somebody in the house that's smoking? Are they using biomass fuels indoors? Are they still working a job where they're getting significant amounts of dust exposure? Is it possible to switch to a different role in that job? On physical exam is rarely diagnostic. Things that you can see on exam, really not a whole lot. You really don't see signs of their airflow obstruction until these patients have significant impairment. So in your early COPD patients, and even in your moderate or severe COPD patients, you're not going to see a whole lot of changes on exam. Differential diagnosis for COPD includes asthma, congestive heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse panbronchiolitis. So you have a patient come in, they have symptoms, they have shortness of breath, they're coughing, they're making sputum. They have these risk factors. They were a smoker. They worked, in an occupation where they had exposures to dust. Um, all of these things point you towards COPD, but you can't say for sure that the patient has COPD until you've gotten spirometry. I see this time and time again where my patient, I see a new patient in clinic and they're like, well, they told me I had COPD. And it's based on a history of them coming into the clinic or into the ER with bronchitis and they're a smoker. But until we get that spirometry, we don't know for sure whether they actually have COPD or whether they're somebody with chronic bronchitis, or maybe it is a quote unquote smoker's cough. So let's move on and talk a bit about spirometry. Spirometry measures the volume of air exhaled at a specific time point during a forceful and complete exhalation after a maximal inhalation. The total exhaled volume is known as the forced vital capacity. The volume exhaled in the first second is known as the forced expiratory volume in 1 second, or the FEV1. And so the numbers that we look at are this FVC, FEV1, and then the ratio of the two, the FEV1 over the FVC. Uh, Typically, we do both pre and post bronchodilator spirometry. So we would do the spirometry, then we give the patient some albuterol, and then we repeat to see how they respond to that albuterol or other bronchodilator. What we're looking for is airflow limitation. We're looking at a post bronchodilator ratio of less than 0.70 or less than the lower limit of normal, depending on if that value is given to you in your lab. Characteristically, when you look at COPD versus asthma, both can have a low ratio, but COPD is irreversible or only partially reversible with a bronchodilator. This is pretty characteristic for COPD versus asthma, which you do see more of a bronchodilator response. And just a reminder that screening spirometry is not recommended. We don't typically go out and do this on patients to see whether or not they have COPD in the absence of symptoms. The role of spirometry is to provide a diagnosis and to assess the severity of airflow obstruction, which helps in prognosis, and then also to follow up on assessment. This helps you to make therapeutic decisions, pharmacologic consideration of alternative diagnoses, and then any type of non-pharmacologic intervention that we may want to perform. It also helps us to identify patients that may be in a rapid decline. Spirometry is the most reproducible and objective measurement of airflow limitation. It's non-invasive and readily available. And keep in mind that peak expiratory flow is sensitive but not specific. So in these diagrams, you can see a normal spirometry here, time versus volume. And again, we're looking at the total volume that they're blowing out, which is the FVC. And then we're looking for the amount of volume that is exhaled in 1 second, which is the FEV1. The ratio of these together makes up your ratio, the number that you're looking at. And here in this normal patient, it is 0.8. You've got 4 liters over 5 liters, which is 0.8. The bottom picture shows somebody with obstructive disease. And again, the FVC is the total volume out, which in this patient is 3.2 liters, versus the total volume exhaled in 1 second, which here is 1.8 liter. And the ratio of those two is 0.56, which is indicative of obstructive lung disease. On the right is again the diagrams that we were just looking at, where you've got your total volume out is your FVC versus your volume in 1 second. The black line indicates normal spirometry. The blue line indicates somebody with obstructive lung disease. The same in this first picture. This is a flow volume loop where you're looking at volume versus flow. The black line, which I always thought looked a little bit like a sailboat. Above the line is the sail, below the line is the boat part. That is normal. And in somebody with obstructive lung disease, you see the blue line where they have sort of this concave scoop out of their expiratory limb here, expiratory being above the line, inspiratory being below the line. Just another diagram of this time in red. This patient has COPD, and again, you can see this, this scooping out of the expiratory limb. Here's a picture of a patient with who received pulmonary function tests, specifically spirometry. This is a 60-year-old female who has 75 pack year history of smoking. If you look at the FVC, it was 1.47 liters. The FEV1 was 0.51, which gives us a ratio of 35. And this is a pre-bronchodilator. This is a post-bronchodilator. And here the FVC is 1.87, the FEV1 0.61 with a ratio of 33. This patient did have a pretty significant change with bronchodilators, but not back to normal. So this is what I talked about as an irreversible or a partially reversible response to bronchodilators. So again, What you're trying to identify with spirometry is a post-bronchodilator, either a fixed ratio of the FEV1 over FVC of less than 0.7, or a number that is less than the lower limit of normal if that number is provided to you in your pulmonary lab. Um, if you use the fixed number of 0.7, that may actually overdiagnose COPD in elderly patients and lead to a less frequent diagnosis in adults that are under age 45. So if you do have the lower limit of normal available to you, that is the number that I would suggest that you use. Um, However, the risk of misdiagnosis and overtreatment in these patients is pretty low, as spirometry is really only one of the parameters that we use for establishing the diagnosis. The FEV1 and the FVC do predict an all-cause mortality independent of tobacco smoking. So if you have two patients that have that are both smokers and you have one that has a lower FEV1 and FVC, that patient will have a higher mortality than the other patient. Abnormal lung function does identify a subgroup of smokers that are at an increased risk for lung cancer. So how do we assess these patients? We've seen them in clinic. We've gotten their history. They have risk factors, host factors for COPD. Our goal of COPD assessment is to determine the level of airflow limitation and to determine the impact that this disease has on the patient's health status. And then we also want to try to determine, are they at risk for future events like COPD exacerbations, hospitalizations, death. And that way, we can sort of help to determine how we can modify these risk factors and how we can hopefully help to mitigate some of these risks. This also helps us to guide therapy for these patients. So when you're looking at the aspects of the disease, what we really want to find out is there a spirometric abnormality? And if so, how severe? What is the current nature and how severe are the patient's symptoms? Are they somebody who has risk factor or who has exacerbations, and what is their future risk of exacerbations? And then do they have any comorbidities that may predispose them to a higher mortality? When we classify their airflow limitation, we can use the GOLD guidelines. And with this, they break down the FEV1 into 4 stages: mild, moderate, severe, very severe. GOLD stage 1 being mild, and this is an FEV1 that is greater than or equal to 80% of predicted. GOLD stage 2 is moderate, and that FEV1 falls between 50 and 80% of predicted. GOLD stage 3 is severe, and that falls between 30 and 50% of predicted. And then GOLD stage 4 is very severe, and the FEV1 in these patients is less than 30% of predicted. When we look at the patient's symptoms, we previously measure breathlessness using something called the Modified British Research Council, the MMRC questionnaire. And that looked specifically at shortness of breath. And we know that there is more to COPD than just shortness of breath. They recommend a more comprehensive assessment, either the chronic respiratory questionnaire, the St. George's respiratory questionnaire. These are both very, very complex, multiple questions, sometimes a little bit difficult to interpret. And so they came up with a shorter comprehensive measure, one of which is the COPD assessment test, or the CAT, and the other is the COPD control questionnaire, the CCQ. This is what we used to use, the modified MRC dyspnea scale. And this is one question. How breathless are you? 0 being I only get breathless with strenuous exercise, and 4 being I'm too breathless to leave the house, or I'm breathless when dressing or undressing, with then multiple levels of breathlessness in between. So one simple question, but again, this focuses only on breathlessness, and we know that there are other features that impact patient outcome. And so with that, the CAT assessment is a great test to use. This is 8 questions on a scale of 0 to 5, with 0 being less symptomatic and 5 being more symptomatic. And so it looks at cough, I never cough versus I cough all the time, mucus, chest tightness, breathlessness, how limited are you in your activities, how confident are you in leaving your home, sleep, and then energy. And so on this scale, you can have a score of anywhere from 0 to 40, with 40 being more symptomatic and 0 being less symptomatic. So we've looked at spirometry and we've looked at symptoms. Now we're looking at exacerbations. So what is an exacerbation? It's an acute worsening of respiratory symptoms that results in the need for additional therapy. Mild, treated with your short-acting bronchodilators. You had to take your albuterol more often. You had to wake up and take it, just an increased use of albuterol. Moderate is you're using your albuterol, but you also needed a course of antibiotics or steroids. Severe requires you to go to the hospital or to the emergency department. Um, every patient is different. There are patients that I treat that have never had an exacerbation. I've never had to put them on antibiotics or steroids. They never have to use their albuterol. And then I've got patients that are in the hospital several times a year. So it really varies between patients. But again, the best predictor of somebody who's going to have frequent exacerbations, which is 2 or more a year, is a history of frequent exacerbations. Mr. Smith gets an exacerbation 3 times a year, like clockwork. He's never going to be a patient who just all of a sudden stops having exacerbations. Mrs. Jones has never had an exacerbation, never has to use her albuterol inhaler, and for the most part will probably stay on that path. So it's there's something more playing a role into this rather than just the diagnosis of COPD. There's some type of host factor, environmental factor, something that puts these patients on a path of being a frequent exacerbator or not. Um, Now, we do know that as airflow limitation deteriorates, patients can have increased exacerbations, risk of hospitalization, and death. And so these patients, again, they're on this path of being somebody with frequent exacerbations or not. But again, this can be modified a little bit. So getting the patients to stop smoking comes in handy. Teaching them to avoid their risk factors or their triggers, again, comes in handy. But for the most part, there are patients who are always going to be frequent exacerbators, and there's patients who won't. One thing that they've looked at is the blood eosinophil count. Is this something we can use to predict who's going to have exacerbations and who won't? There's a post hoc analysis of 2 clinical trials in COPD patients with an exacerbation history showed that there was higher blood eosinophil counts that may predict increased exacerbation rates in patients who were treated with long-acting beta agonists. These findings suggest that eosinophils are a biomarker of exacerbation risk in those patients with a history of exacerbations, and they can also predict the effects of steroids on exacerbation prevention. There was an increased, what they found was that they think that there was an increased effect of steroids in COPD patients with higher blood eosinophil counts. So this study recommended that in those patients who were frequent exacerbators who had higher eosinophil counts, that they get put on an inhaled corticosteroid as well as their LABA and their LAMA treatment to hopefully help to prevent exacerbations. We also want to look at comorbidities. This can occur in patients with any severity of disease, mild disease, severe disease, very severe disease. They can all have comorbidities. This is an independent risk factor for mortality and hospitalizations, and COPD may actually increase the risk of you having other disease. In addition, COPD also has extrapulmonary effects. It doesn't just affect your lungs. It can cause weight loss. It can cause nutritional abnormalities. It can cause skeletal muscle dysfunction, and which then leads to weakness and fatigue. So we'll move on to the revised combined COPD assessment. So previously, when I first started my training, we were using the gold staging. And what that consisted of is you got spirometry, you matched the patient up with their FEV1 and where they fit on that table, and they had COPD stage 1, 2, 3, or 4. And that only took into account their spirometry. It didn't take into account anything else. And what we found is that you could have two patients with the same FEV1 that behave very, very differently. And so in 2011, the GOLD guidelines came out with this ABCD assessment tool. And this took into account patient-reported outcomes, and it called to light the importance of exacerbation prevention in the management of COPD. But what they ended up finding is that this assessment really was not any better than what we had been using, which was just the spirometry in terms of predicting mortality or other important health outcomes. And this is because there were multiple items in this assessment that could change the outcome. And it was somewhat confusing for people to use. And this was the initial tool that came out in 2011. And so what you see here is on the left-hand side, you see your spirometry. And this is based on your FEV1. You see 1, 2, 3, and 4 going from the bottom to the top. On the right-hand side is risk of exacerbation histories, 0 or 1 exacerbations requiring hospitalization, or 0, 1, let me think about how this was phrased back in 2011. I think it was just number of exacerbations, 0, 1, or 2 or more. And then along the bottom, you see symptoms. And at this time, they used either the MMRC or the CAT. And if you were less symptomatic, you were on the left. And if you were more symptomatic, you were on the right. And so if you look at these boxes, A, patients are lower airflow limitation, less exacerbations, less symptoms. B is more symptoms, but still low risk, a low FEV1, or a higher FEV1 and a lower exacerbation. Above the line, C patients had a worse airflow limitation, but were less symptomatic. And then D patients had lower FEV1, were more symptomatic, were more likely to have exacerbations. And so this became confusing when you had somebody who was symptomatic, but they had 2 exacerbations, but their FEV1 fell into class 1. So where do they fit? Are they B? Are they D? And how do you treat them? Because what the GOLD guidelines then went on to do is say that patients in group A should receive this treatment, B should receive this treatment, C should receive this treatment, and D should receive this treatment. So if you have a patient who could be B or could be D, how should you treat them? And so it was a little bit confusing for people to place patients into and then determine exactly how they should be treated. And so they came up with this revised assessment. And what this does is it separates spirometry from your A, B, C, and D groups, and you use both to provide a diagnosis. The number provides information regarding the severity of your airflow. And that is important because FEV1 does help to predict your clinical outcomes, such as mortality and hospitalization, and can also prompt you to think about non-pharmacologic therapies. And then the letter provides information regarding symptom burdens and your risk of exacerbations. And then this can be used to guide therapy as well. And so with this, you have spirometry that confirms your diagnosis and tells you the severity of your airflow limitation. And that gives you a GOLD stage 1, 2, 3, or 4 based strictly on your FEV1. And then you have an assessment of their risk factors and their exacerbations, which looks similar to what you had before. You've got your symptoms along the x-axis and your exacerbation history along the y-axis. And so now you can see it can only be A, B, C, or D. There's not a risk of you fitting into multiple categories based on how you answer your questions. And so now what they recommend is patients are given a number and a letter. So COPD 3B or 1A or wherever patients would fit. And so patient 1 had an FEV1 of 30% predicted, had a CAT score of 18, and had no exacerbations in the past year, versus patient 2, who also had an FEV1 of less than 30%, also had a CAT score of 18, but had 3 exacerbations in the past year. And so with the FEV1 of less than 30% predicted, both of these patients would fall into the gold stage 4, very severe. If we use the assessment that was published back in 2011, you can see where you would put patient 1 up here in C. Their FEV1 puts them at a 4. Their CAT score, actually, sorry, puts them over here at D, 18, but they've had no exacerbations. Well, that puts them down here at B. So are they a B or are they a D? Versus patient 2, who is pretty clear cut. Their FEV1 is 30, their CAT score is 18, and they had 3 exacerbations. They clearly fall into D. And so this is, again, demonstrating why this was a little bit confusing. Using the refined assessment with these same 2 patients, patient 1 is less than 30% predicted, so they would be given a 4. A CAT score of 18, which would be over on the right side, and no exacerbations in the past year would be B. So this patient would be 4B versus patient 2, also less than 30%, so they're a 4. A CAT score of 18, but they had 3 exacerbations, so they would be a 4D. Leave that there for a second. So the refined assessment is used again to not only tell you how severe their COPD is, but what degree do they have symptoms, and then to help predict mortality and also determine treatment. But before we get into that, what additional investigations should or need to be done? One thing that is recommended, the WHO recommends that all patients with a diagnosis of COPD should be screened for alpha-1 antitrypsin deficiency. A low concentration, less than 20% of normal, is highly suggestive of homozygous deficiency. And if a patient does screen positive for alpha-1, they do recommend that patients' family members should also be screened. What imaging studies should be done? Chest x-ray is not useful in establishing a diagnosis, but it is useful to exclude alternative diagnoses and establish significant comorbidities. Changes that you can see on x-ray include hyperinflation, hyperlucency, rapid tapering of vascular markings, and flattening of the diaphragms. CT scan is not routinely recommended to establish a diagnosis, except for if you are trying to determine whether these patients have bronchiectasis or in the case of lung cancer screening. It also may be helpful in diagnosing comorbidities and evaluating for possible lung volume reduction surgery. This is a chest x-ray of a patient with COPD. There is an increase in the space between the ribs. There's also some flattening of the diaphragm. This is a CT scan for a patient with COPD, and you can see that they have lots of blebs located in the right lung. I'm sorry, left lung. Excuse me. Lung volumes and diffusion capacity. So spirometry is essential for diagnosis of COPD. Lung volumes and diffusion capacity are also important, not mandatory for diagnosis, but are helpful. Gas trapping can be seen even in early stages of disease. I have several patients that's the only symptom that we see is an increase in gas trapping on their lung volumes. As their disease worsens, their hyperinflation will increase, which will also be seen in the lung volume portion of the test. Diffusion capacity provides information on the functional impact of emphysema. And so if you have this patient whose breathlessness seems to be far out of proportion to the degree of airflow limitation, they have gold stage 2 on their FEV1. But they're very, very symptomatic. DLCO may shine some light on that. A low DLCO may indicate that they have fairly severe emphysema contributing to their symptoms. Oximetry and ABGs help to determine the need for supplemental oxygen. Pulse oximetry can be performed in all patients with clinical signs suggestive of respiratory failure or right heart failure. If peripheral oxygen saturation is less than 92%, then blood gases should be assessed. Exercise testing and assessment of physical activity. Exercise impairment is measured by a reduction in the patient's 6-minute walk test distance. This is an indicator of health status impairment and a predictor of prognosis. It can be used to assess disability and risk of mortality, as well as to assess the effectiveness of pulmonary rehabilitation. Testing using a cycle or a treadmill ergometry can also assist in identifying other alternative conditions such as cardiac disease. And this should be done on a patient-by-patient basis. There are these composite scores that pull in multiple variables that can help identify patients that are at an increased risk for mortality. They look at the FEV1, exercise tolerance, weight loss, reduction in arterial oxygen tension. The BODE index is a very common one. This stands for body mass index, obstruction, dyspnea, and exercise. This gives a score that is a much better predictor of subsequent survival than any other single component on its own. And so here's a diagram of that. So again, BODE is body mass index, and you get 0 points if you're greater than 21, 1 point if you're less than or equal to 21. O stands for oxygenation. Obstruction, and that is your FEV1. And you can see you get anywhere from 0 to 3 points. Fewer points, the higher your FEV1 is. More points, the more severe your disease is. D is dyspnea, and that for this they do use the MMRC. Again, fewer points, the less symptomatic you are. More points, the more symptomatic you are. And then E is exercise, which is distance walked in 6 minutes. The further you can walk, the fewer points you get. You add these points up, and the fewer points, the better the the lower your mortality over the next 5 years. And I thought I had those numbers in here, but I don't. I apologize. I can get those to you though.
You have a question in the chat.
Sure.
It says, how does COPD affect oxygen saturation and end tidal CO2? What guidelines would you give a provider who wants to use conscious sedation on a patient with COPD?
So the first question is, how does COPD affect oxygenation? So when you have damage to the lung parenchyma, it does not function as normal. And so remember the linings of the lungs, the alveolar sacs, is where oxygenation and gas exchange occurs. And so if that tissue is not functioning correctly, it's not participating in gas exchange. And so you're not able to bring in enough oxygen, and you're not able to effectively clear your carbon dioxide. And so oxygen levels can go down, carbon dioxide can go up. And so the more destruction you have to the lung tissue, the more emphysema that is seen, the less functional lung tissue you're going to have. And so the more problems you'll have with your oxygenation. As far as advice to give for conscious sedation, there are some prediction models that can be used to determine how well a patient would do and what the likelihood is of them having complications related to their surgery. A lot of these things have to do with what their baseline oxygen level is, and whether they've had recent respiratory infections. And it's really going to have to be on a case by case basis of how well the patient's doing. They are at a higher risk for having pulmonary complications if there's somebody who has had a recent respiratory infection, somebody who has a lower baseline oxygen level, or somebody who needs oxygen. That does put them at a higher risk for having surgical complications. So it really needs to be done on a patient by patient basis. So, and I do recommend to all of my patients that if they do have a respiratory infection, they should wait for about 30 days after that before scheduling their procedures. So.
Thank you.
Mhm. So we'll move back to the patient that we had at the beginning. This is our 63-year-old male patient with shortness of breath. It's been worsening over the last few years, frequent bronchitis, although has not required hospitalization. Former smoker, 2 packs a day for 35 years, but quit smoking 8 years ago. Symptoms include cough, productive of sputum, low energy, and shortness of breath with his daily activities. His oxygen saturations are 94% on room air. So, taking everything that we know, um, this was our patient that we looked at those spirometry the spirometry on. Um, And based on that spirometry with his FEV1 of less than 30%, he is a gold grade 4 with his symptoms and his frequent exacerbations. That does put him in a group D. So gold grade 4, group D COPD. What evaluations does he need to make the diagnosis and determine prognosis? We should do this refined assessment score, spirometry, exacerbation history, evaluation of symptoms. Also, because he is a new diagnosis of COPD, he would be a candidate for alpha 1 antitrypsin screening because he does meet the criteria 2 packs of cigarettes a day for 35 years and who quit less than 15 years ago. He would be a candidate for a low dose CT scan to screen for lung cancer. And with his oxygen saturation of 94%, you could also send him for a 6-minute walk test. Not only does that determine whether he would need oxygen with exertion, would also be a standard prior to starting pulmonary rehab if you were going to send him that way, and then would also help prognostication as that is a component of the BODE index. So, in conclusion, COPD is the fourth leading cause of death in the United States. It's responsible for high resource utilization, frequent clinic visits, frequent hospitalizations, and a need for chronic therapies. Patients with symptoms and exposure to risk factors should undergo spirometry testing for COPD staging. Remember, though, that airflow limitation alone is not enough to completely assess these patients, and that the refined ABCD method uses airflow limitation as well as symptomatic assessment to classify these patients and to guide their treatment. Our objectives and then resources. And I'm going to go back real quick because I do think that I have slide. Oh, I did not. Okay, I thought I had it maybe in my notes. I do not have that, but I can get those numbers for the BODE index and what that means for mortality. So, thank you all very much, and I'm happy to answer any other questions that you may have.